Hola, bienvenidos al segundo día de nuestro congreso. Soy Pilar Leal, cirujana de trasplantes y miembro del comité científico. A nombre de nuestra mesa directiva, les agradezco el que nos acompañen y espero que estén disfrutando nuestro programa. Es para mí un honor presentar al ponente de nuestra conferencia magistral del día de hoy, el profesor Mohamed Rela. El profesor Rela es un pionero en trasplante hepático y cirugía HPB con más de 28 años de experiencia. Originario de Tamil Nadu, se graduó como médico en 1980 de la Universidad de Madrás, en India, y de cirugía general del Royal College of Surgeons de Edimburgo, en el Reino Unido, en 1988. En 1991 se unió al King's College Hospital, donde actualmente es profesor de cirugía hepática y trasplantes. En 1997 lideró al equipo que exitosamente trasplantó a una niña de 5 días de nacida, hecho con el que entró al libro de récord Guinness. El profesor Rela desarrolló en Londres la experiencia más grande a nivel mundial en trasplante hepático usando la técnica de split. En 1999 realizó el primer trasplante hepático de donante vivo en un paciente con insuficiencia hepática aguda. Y también en este hospital desarrolló la experiencia más grande en el mundo en trasplante hepático auxiliar. En 2019, profesor Rela regresó a su natal India, donde fundó el Instituto de Trasplante y Enfermedades Hepáticas en el Global Hospital en Chennai, convirtiéndolo en el programa de trasplante hepático más grande del subcontinente. Desde su fundación a la fecha, se han realizado más de 1.500 trasplantes hepáticos en este programa. Gracias a los esfuerzos del profesor Mohamed Rela, Chennai es hoy la región con la tasa de donación cadavérica más alta de su país, 7 veces mayor a la media nacional. En 2013 recibió el doctorado honoris causa por parte de la Universidad de su estado natal, como reconocimiento a su incansable labor en la atención a la salud. El profesor Rela es pionero en la técnica de split para trasplante hepático y es uno de los cirujanos pediátricos más innovadores, realizando constantemente reportes de novedosas técnicas quirúrgicas, como el trasplante hepático de donante vivo, el trasplante hepático monosegmentario, particularmente para neonatos, y el trasplante auxiliar parcial ortotópico. Desde 2011, el profesor Rela organiza el Masterclass in Liver Disease, el cual se ha vuelto rápidamente una de las reuniones más importantes en Asia, la cual les recomiendo ampliamente. En 2019, el profesor Rela fundó Dr. Rela Institute and Medical Center, con el objetivo de atender a la población local en instalaciones que cumplen con los más altos estándares a nivel internacional y ofrecer tratamientos especializados como trasplantes y cirugía HPB compleja a precios accesibles. Rela Institute cuenta con 450 camas de hospitalización, de las cuales 130 son de terapia intensiva. Esta terapia intensiva conforma así una de las unidades más grandes especializadas en la atención de pacientes con enfermedades hepáticas o posttransplantados. El profesor Mohamed Rela es chairman y director ejecutivo de Rela Institute and Medical Center, profesor de cirugía hepática y trasplantes en el King's College Hospital NHS Trust de Londres y director del Fellowship en Trasplante Hepático en la Universidad de Tamil Nadu. Actualmente, el profesor Mohamed Rela es presidente electo de la Sociedad Internacional de Trasplante Hepático, ILTS por sus siglas en inglés, para el periodo 2021-2022 y es miembro del Consejo Consultivo del Grupo Internacional de Estudio de Trasplante Hepático de Donante Vivo. El profesor Rela es considerado uno de los mejores cirujanos de trasplante hepático en el mundo. Hasta la fecha ha realizado más de 4.500 trasplantes hepáticos, cuenta con más de 600 artículos publicados sobre trasplante hepático y cirugía HPB compleja. El profesor Rela es editor de la revista de la Asociación India para el Estudio del Hígado y editor asociado de Transplantation, revista oficial de la Sociedad de Transplantes ITS. Además, es revisor en las revistas de mayor impacto en su área. Profesor Mohamed Rela, muchas gracias por aceptar nuestra invitación y acceder a compartir con nosotros su experiencia en realizar trasplantes y cirugía HPV compleja en un país en desarrollo. Bienvenido.
Hello, good evening. My name is Dr. Mohamed Rela. I'm one of the liver transplant surgeons working in India at the moment. And thank you very much for inviting me to speak to the Mexican HPB surgeons. I was asked to talk about setting up or developing HPB and liver transplantation center in an Asian country. I just want to go through my journey because it's important to know my background to see how I've developed a center in Asia. Now, the transplantation was not well developed when I was training. I went into transplantation almost now 28 years ago. It wasn't well developed in the Eastern countries, and I went to the UK to train generally in surgery and then specifically in transplantation. But however, over the last 20, 25 years, Asian countries have slowly developed in the field of living donor liver transplantation. What has been a little backward in the East has caught up in a huge amount. Specifically in India, liver transplantation took a long time to develop because in the early days of transplantation, the Indian surgeons wanted to develop cadaver liver transplant programs, but that wasn't really a reality because the cadaver numbers were very small. And part of the reason why the cadaver numbers were very small was that there was a huge problem culturally, and there were religious barriers. The trust in the hospital system was not good. And the countries were not very good with developing infrastructure as well as legislation. Yeah, when you look at the organ donation rate in various parts of the world, India did not even appear in the donation rate, whether it's a DDLT or LDLT over the period of time. And you can see the Eastern countries like Japan and Korea are also lagging behind in a big way in terms of the DDLT number. I just put a picture of really the stalwarts who developed living donor liver transplant program in the East, mainly from Taiwan, Korea, and Japan. And these people have been instrumental, and Hong Kong, and instrumental in developing really living donor liver transplantation in the Eastern countries. And Korea really is as a model for the rest of the world, because not only did they develop living donor liver transplant, they also developed disease donor simultaneously, and a third of the liver transplants done in Korea are now disease donor liver transplant. Now, in India, there has been a huge problem. First of all, the legislation didn't come into existence for a very long time. And then there was a huge problem with organ donation, living donor liver transplantation on the kidney side, because there was a lot of complaints about organ trading and people having their organs removed for money, and the poor people were being exploited. So India had a very poor reputation for transplantation. And in that background, really, the living donor liver transplantation did not pick up in a big way. Now, the first attempt at cadaver transplantation in India took place in 1995. And it was 3 years later was the first successful cadaver transplant. And then it was in 1999, I went to India, to Bombay, to do a living donor liver transplantation, a left lobe in a child. And that was the first successful living donor liver transplant in India. And the cadaver situation was so bad, really. The Indian surgeons then started moving towards the East and learning really techniques of living donor liver transplantation. And only when people started doing living donor liver transplantation, the transplantation became a reality in our part of the world. And during this time, really, and as soon as living donor liver transplantation started becoming popular, the number of transplants in India exponentially started increasing. And now almost 90% of the transplants done in India are living donor liver transplant, maybe around 10% to 15% maximum would be the disease donor liver transplant. And now the number of centers in India are probably over 100 living liver transplant centers in India. And the city where I am, there is already about 5 or 6 liver transplant centers. And how did really liver transplant become successful in our part of India is about, I think it's an individual effort which made liver transplantation rather than a state effort. If you look at the public sector and the private sector, majority of the liver transplants in India are done in the private sector, and less than 5% of the liver transplants are done in the public sector. So you have to say that's the effort of the individuals which made it possible. And the other reason how it was successful is the cost of transplantation in India is significantly lower. We can do liver transplants for about $35,000 in India, compared to the US or UK, where it would cost anywhere between $250,000 to $400,000 in the Western countries. And in China, it's about $65,000 to $70,000. We are almost 50% of the cost of liver transplantation in India. And that made it possible for patients to really get transplants done in the private sector. And I just put this slide to indicate to you, you might think that the way to start liver transplant in a new country would be through deceased donor, because deceased donor transplant is seen as a safe bet without the risk to the donor, and therefore everyone should start with a deceased donor. But paradoxically, deceased donor was not successful in India, whereas living donor became extremely successful in India. The reason is, for deceased donor, you need a system. You need the governmental bodies to allocate the allocation system, the retrieval system, the transplant coordination. Everything requires a system. And I have to say, in our countries, people are not very good with following systems. Whereas the LDLT is an effort of an individual team. You just have to have an extremely capable surgeon to build a team around him. And it doesn't require much more interference from outside bodies. And that is why I think LDLT became more successful in India than DDLT. Now, during this period, I was in King's College Hospital training initially, and I was appointed as a consultant surgeon in 1994. So I've been a consultant for almost 25 years, and I was appointed professor of liver surgery in 2004. And I was also in charge. I was a clinical lead for the HPB surgery and pancreatic surgery at King's College Hospital. And this is an early picture of mine from King's. And I took an interest in two things when I went to King's. One was a split liver transplantation, and the other was, three really, auxiliary liver transplant, as well as really an interest in pediatric liver transplants, particularly a transplantation of the neonates. And if you look at the earliest publications of split, and this is a publication in Annals of Surgery almost 20 years ago. This was published in 1998, 22 years ago. Our series was, the largest series you see is a combined European series with 98 patients, and our series with 41 patients. Had much better survival results, 90% patient survival, 88% graft survival. This one has an equivalent survival, but the graft survival was 75%. In the early days of split liver transplantation, one of the major issues was about the complication rates, biliary complication rates, and vascular complication rates. And we were the people at King's to demonstrate that the right lobe was as good as a whole liver transplant. So really, at British Journal of Surgery at that time, this is again 1998, asked me to write a leading article about split liver transplantation. And we were the ones in King's who popularized really split liver transplantation in the UK. And we demonstrated by using a split for children also, the outcome was extremely good in the pediatric liver transplantation. And we showed that the children were not really disadvantaged by split liver transplant, and neither were the adults disadvantaged by split liver transplant. The next interest of mine was, in fact, a transplantation of neonates. And when I first went to King's, the survival of children, this is almost 25 years ago, the survival of children under 3 months of age was almost 50%. There was a 50% perioperative mortality. And part of the reason, and we are talking about children who are under 3 kilograms or under 4 kilograms, when we implanted a left lateral segment, they had a very large liver, and you couldn't actually close the abdomen when you implanted these livers. And they also didn't stay in, so they had outflow obstruction. You had to close the abdomen with silastic mesh that resulted in leakage of fluid, difficulty with fluid balance, and also there was difficulty in extubation because when you close these abdomen tight, it tamponaded the diaphragm, and these children did not extubate from the ventilator early. So there were many, and the outlook for these children was not very good. And at that time, we developed this technique of what we call monosegment transplantation, where we took away, this is somewhat a non-anatomical reduction of the left lateral segment. We took away the left lateral part, the segment 2 part, and all. You could do this on the bench. You just have to probe the segment 3 vein, and then you could take as much as possible on the left side. And as soon as we reduce these livers, the survival of these infants improved. If you see, no child is more than 4 kilograms. I think the largest child is 3.9 kilograms. All the other, and there was one 5.49. But the outcome of these children improved dramatically. There was only one retransplant for hepatic artery thrombosis. The child died. So you got an instantly a 50% survival to an 85% survival. And we did the early parts. In the early parts, we didn't do living donor. These were done as monosegments of cadaver livers. And this is a pediatric cadaver liver, which is reduced into a single segment. Now, there was still a problem, particularly when the left lateral segment is thick in size. You couldn't still close the abdomen. You can see this was really a 3-month-old child. Look at the size of my hand relative to the size of the child. This liver is too thick and you couldn't close the abdomen. And this is when this technique of reducing the thickness of the liver was developed. And this was actually developed by Kasahara. This is a picture taken in King's some 20 or 18 years ago. When Kasahara used to work, he's a Japanese professor who does a lot of pediatric liver transplant. And he developed this reducing the thickness of the graft. And he included me as one of the authors of this paper, where we actually do an anatomical reduction. And this really has resulted in transplantation of the youngest child ever to have a transplant. And this child had a transplant at 5 days of age. So this is the child who had a transplant at 5 days of age. And I found this video on YouTube. And you can see this family had lost already 2 children due to congenital hemochromatosis. And this child was diagnosed to have congenital hemochromatosis even before the child was born. And as soon as the child was born, developed signs of liver failure. And we listed the child and got a cadaver organ, which was reduced to a monosegment. And the child is, this girl is now 22 years of age. And I'm speaking in the press conference at that time, I think this was year before the year 2000, I think 1999 was the time this operation was done. And this is the same girl, some 22 years later. She is a law student in Dublin. What is amazing is she's on very little immunosuppression. She never had a scan. She never had a liver biopsy. So when neonates have a transplant, they hardly have a problem of rejection or any immunological issues with the liver. But we don't know what the shape of this liver would be because it was a monosegment at that time. I also had an interest in auxiliary liver transplant, and there have been many publications on auxiliary liver transplant. And you can see when you do an auxiliary, this is for acute liver failure. You do this for the native liver to regenerate. And the first picture is the left-sided auxiliary liver transplant. And then as you slowly withdraw immunosuppression, the graft will reduce in size and atrophy. And the native liver has slowly grown in size, and then you withdraw immunosuppression. And in King's, we've probably done almost 150 auxiliary liver transplants for both acute liver failure and metabolic liver disease. And that's been one of the largest experiences around the world. And I also really had I was driving the pancreatic program in King's at the time, and also have done a few ex vivo liver surgery. Now, with this background, I come to India, and people, when I wanted to come to India, people told me that that was a bad idea. Getting a professor's post at King's College Hospital in London, you want to go and venture into India and start a program, and they thought that I might just disappear from the world of transplantation. And I went into a private hospital, a hospital belonging to a friend, to start a liver transplant program. And this is almost 10 years ago. Initially, I went with a sabbatical and partly traveling from London, but a year later, I decided India is where I wanted to work. And now we have a large hospital, 450 bedded hospital, named after me actually as Rela Institute. Transplantation is our main interest and critically ill, but this is a multi-specialty hospital. We do all specialties. And when I moved from the other hospital to this hospital, almost 270 of my staff really moved with me into the new hospital. This probably has one of the best liver intensive care anywhere in the world, actually. This is our liver intensive care. We have 26 bedded liver intensive care, and we currently do a little over 250 liver transplants a year. And I maintain my interest in HPB surgery, and we have a large volume of work with advanced cholangiocarcinoma. I'm not going to go into that. This is one of the techniques of on-block cholangiocarcinoma using the Rex rhesus. I would, any of you want to read this, I think this is a very interesting new technique for cholangio. And I've also done many ex situ many resections for intrahepatic cholangiocarcinoma. Here you can see that the tumor is involving all three hepatic veins. Just a segment of left hepatic vein is free. So we took this liver out and then resected and reimplanted the left lateral segment. So everything that can be practiced in the Western world can be really practiced in India. And I come from India, and I went into the city from where I studied and I worked after 25 years, and to contribute to our population, to our patients and our children. And I believe that transplantation transforms a life. You can look at this child. He would have never had a chance of a transplant before. Now the government is funding many bodies, many private individuals are funding transplantation for children. And this picture was taken only 3 months after liver transplant for this child. I've been here for 10 years, and I've done over 2,000 liver transplants. This is up to March 2020. We have a large pediatric program doing about 450 pediatric liver transplants. The good thing about our program is 25% of our transplant numbers is actually cadaver liver transplants. Disease donor is something that is well developed in our part of the country, particularly in India. The southern states where I come from, Tamil Nadu, is where the maximum number of organ donations also take place. So there has been a huge improvement, both in terms of LDLT as well as DDLT. We probably are one of the largest centers, maybe in the world for pediatric liver transplants. This is till March. This is COVID time. It stops. I think now we have done so far almost 45 liver transplants. The numbers for this year have been slightly low because of COVID. So we do around 65, 67 pediatric liver transplants a year, and hopefully next year the numbers will go back up again. So in 10 years, we have done about 450 pediatric liver transplants. And the outcome have been exactly as good as any Western centers. And this is 1 year overall outcome for LDLT of around 90% and for DDLT of 86%, and for pediatric overall outcome of over 90%. So it is not that we had inferior outcome. And we have been able to do everything that I demonstrated that we did in King's. We have done a large number of monosegment liver transplants. It's been good for me that I come back to my country and to my state, and really recognized by our government. And this is, you see our chief minister and governor of our state offering a DSc honoris causa for me from the university. And the work has been, I think, well recognized internationally. I'm now the president-elect for the ILTS as well. And I'm grateful for the support of the colleagues all around the world for coming into this position. And we've published well as well in India. I think in the COVID period alone, we published almost 30 publications, and I have over 600 publications. And while I was in India, that I was asked to write a chapter on Gray's anatomy, on the anatomy of the pancreas. So the recognition for me has even been better after coming to India than when I was in King's College Hospital. And there have been many, many reviews that I've been asked to write, particularly for auxiliary liver transplants for metabolic liver disease and for acute liver failure in liver transplantation. And one of the things that we did, which is a new technique, is we did a cross auxiliary, where we had 2 patients with metabolic liver disease, liver-based metabolic liver disease, non-cirrhotic, and we swapped the liver. So we had a patient with Crigler-Najjar syndrome and a patient with propionic acidemia. So we took the right lobe of the left lateral segment of Crigler-Najjar and put it into propionic acidemia, and the left lobe of propionic acidemia and put it into Crigler-Najjar. And the 2 metabolic disorders canceled each other. And this is a patient who's 2 patients transplanted without any donors. And we have a lot of activities in terms of educational activity. We run what is called Masterclass in Liver Disease, which is attended by almost 1,000 delegates from 25 countries. And this is a very successful program. And many of people from the ILTS have come and taught in this. And we have training programs both for Indian surgeons and overseas surgeons. And the program is well recognized in the Middle East. And there are many countries who have contracted with us for sending their patients for transplantation. And Oman is one example. The Oman as a country, all of the patients requiring transplantation from the country of Oman and also Bahrain would only send their patients to our program for transplantation. And we offer transplantation for adjoining countries like Sri Lanka, Bangladesh, where there is no big transplant program yet. And finally, I think we've moved with time, and recently we acquired a Davinci Excise system. This is only 4 months ago, and now we have done 10 pediatric living donor left lateral segment completely, and we are partially completing the right lobe, and I'm sure within a month or so, we'll be doing the right hepatectomies also through the Davinci system. So I want to finish off by telling you that even though I've come into a developing country where the resources people feel are not there, when you've got the means are there, and if you're able to do it, you can actually do a very successful program compared to any Western country. And that would be the advice I would give to the Mexican surgeons there, that if you have the will to develop something, I'm sure you can do as well as any North American or European country. And thank you very much. And when this is presented, I hope to be there and I can answer questions. Thank you.